CIDP or the chronic inflammatory demyelinating polyneuropathy. It is a heterogeneous group of immune mediated neuropathies which affect peripheral nerves and the nerve roots. It's a relatively common disorder in the range of 1 per lakh incidence is around. Typical CIDP is the most common subtype, accounting for more than 50% of all cases. And in that, it is a fairly symmetric sensory motor polyneuropathy, characterized by the proximal and distal muscle weakness that exceeds sensory loss and have a progression or relapse of the disease lasting at least more than 8 weeks. NCV will show the features of demyelination with velocity less than 70% of normal in motor NCV. CSF will reveal raised protein, normal cells, and nerve biopsy can help. Now, some of the variants are quite important of the CIDP because they respond poorly to the steroids and may require IV gamma globulins or the rituximab or the monoclonal antibodies. One of them is the multifocal. When the distribution is multifocal, this is known as the MADSAM. In these cases, asymmetrical multifocal picture is there. There may be mononeuropathy or the focal neuropathy as a variant of CIDP. One more variant is the what is known as the DATS, distal and sensory predominant variant of CIDP. This is more slowly progressive with length dependent symmetric sensory or sensory motor dysfunction in the lower extremities with sparing of the proximal limbs. These patients are more likely to have a monoclonal gammopathy, especially IgM, and again they respond poorly to the corticosteroids and the immunosuppressive drugs, so may require IVIG. Few comment about the Sjogren syndrome, in which we can have the similar kind of the picture, which is basically systemic autoimmune disease, in which we can have the distal symmetric axonal degeneration of the sensory fibers, or there may be ganglionopathy, there may be the small fiber neuropathy, and that is the one of the most common variety is this one. Then there may be the sensory motor polyneuropathy. Rare type, it may have the autoimmune demyelinating polyneuropathy, but anyway, the NCV would be abnormal. Few word about the CanoMed neuropathy, and the acronym stands for the chronic ataxic neuropathy, ophthalmoplegia, immunoglobulin, IgM paraprotein, cold agglutinin, and the dicyclosil antibody. This is rare syndrome characterized by the chronic neuropathy with sensory ataxia, ocular and bulbar motor weakness in the presence of a monoclonal IgM reacting against the gangliosides containing the dicyclosil epitopes. Again, may respond poorly to the steroids. Another interesting variant of the CIDP is when there is an isolated sensory ataxia with normal nerve conduction studies. However, the SSEP may be abnormal, and the MRI may show the radical roots involvement by showing it the enhancement pattern. Now, coming to today's question of IAN, in that a 35-year-old male has presented with progressive ataxia, subacute progressive ataxia and numbness. Examination reveals sensory ataxia without motor weakness. NCV is normal except for the SSEP, which is abnormal. CSF is showing mild increase in the protein with pleocytosis, normal cytology. Blood is showing the lymphocytic pleocytosis. Now, serum protein electrophoresis is normal, so there is no IgM antibodies or gammopathy, and PET scan excludes malignancy. However, it is revealing some increased metabolic activity in the spinal root, suggestive of the roots involvement. Now, let's come to what is the likely diagnosis. Distal acquired demyelinating symmetric neuropathy, unlikely because the NCV is normal. Then chronic immune sensory polyneuropathy, most likely this NCV would be normal except for the SSEP abnormality. Sjogren syndrome usually present with the axonal degeneration. NCV would be abnormal. And CanoMed, in which again these features like chronic ataxic neuropathy with ophthalmoplegia and M protein are not there, so that is unlikely. So the answer is chronic immune sensory polyneuropathy, especially an interesting variant as NCV, both motor and sensory conduction velocities are normal. Only abnormality would be in the SSEP, and they may respond very poorly to the steroids or the immunosuppressive drugs. The drug of choice is the IV gamma globulin or the monoclonal antibodies. Thanks.